Thanks.
Hi, Jason.
Hey there.
Hi, I'm Jan. I think I've been emailing both you and Denver.
Fantastic. Nice to put a face to a name.
Same with you. Same with you. And this is Dr. Lucy Potter as well, who's the other presenter today.
Lucy,
Nice to meet
fine. Oh yeah, you're right.
Thank you. And Sam's also our co-host as well. So I'll just do some quick intros.
Right, great. So welcome everyone to our fourth and final webinar of the year. We're really happy to hear from our amazing speakers today. We'll be talking a bit about the health needs and healthcare provision of patients who are sex workers. So this is a topic I feel like we rarely get taught on, so I'm really happy to hear from you all today, and I hope everyone's just excited to hear from you as well. So just to introduce ourselves a bit and who we are. So like Janani said, so I'm Sam. I'm one of the coordinators for the Faculty for Homeless and Inclusion Health Student Network, along with Jan. And we're a group of healthcare students from any discipline with three primary aims of education, collaboration, and advocating for inclusion health. So if you'd like to join the student network, please sign up to the newsletter, or you can email us as well, especially if you want a more active role in the student network, as we'll be handing over the committee this summer. And you can be sure to follow us on social media too. So before hearing our first speaker, I'd like to say just some housekeeping stuff. So if we can all be respectful of this space and keep our mics muted whilst hearing from the speakers. And if anybody had any questions, feel free to put them in the chat box or ask at the end of the presentation too. So I'd like to present our first speaker. So it's Dr. Lucy Potter, who is an academic GP in Bristol. They run an outreach clinic for street sex working women as part of their homeless health service and have a background in domestic violence and health. So I'll hand the stage over to you, Dr. Potter.
Hello. Right, I'll just share my screen. Fab. Can you all see that? Brilliant. And I have been having some mic trouble, so if I suddenly go mute, just shout or wave and I'll work it out. Brilliant. Thank you for having me along. So yeah, my name is Lucy. I'm a GP in Bristol, and part of, I suppose, my kind of experience here is that for 5 years I ran a drop.
Oh, I think you've gone mute, Lucy.
I'm back.
Yeah.
Good. I'm trying not to get paranoid that something external is taking over my computer and keeps muting me. Feeling very silenced. Anyway, I'll continue. So some of it relates to clinical work, but kind of off the back of that, I'm from kind of speaking to patients and other staff at the drop-in centre. Then my kind of research, kind of academic direction has very much moved into that sphere, because I was recognising that lots of the patients I was working with were getting really inadequate healthcare. So that's kind of driven a lot of my passion here. Probably my slides will move on. There we go. So brief, and I understand I've got 25 minutes-ish, is that right? Yeah, if it looks like I'm going over, just wave at me and I will stop or wrap up rapidly. But I'll go basically a bit on a kind of what do we know with regards to street sex work particularly. That's my kind of experience really. There is a huge, as you'll hear this evening, there's a huge range of what sex work means. But this is kind of my end of the expertise really. And some of the experiences, some of the data that we've got, but then really crucially, like how can we do this better, because there's huge scope to provide healthcare better for sex works. And within that I'll talk a bit about bridging gaps and the connection study. So where it all began was this very lovely drop-in centre that is very close to my heart. So it was a collaboration with 125, which is a charity in Bristol, and I was the drop-in, the GP one afternoon a week in the kind of back room of this drop-in centre. And so, you know, street sex working women in Bristol could come to this space 4 days a week, and they could have a sleep, they could have some food, they could get some clothes, some condoms, they could, you know, on certain days access different health services or substance misuse expertise or housing advice or that sort of thing. Yeah, that's kind of where it all started. Severe and multiple disadvantage is the kind of focus that I have, that I'm kind of focusing on in my ongoing work. And the reason behind that, so you might have heard of the term severe and multiple disadvantage, but there does seem to be kind of slightly differing definitions. And I think some of that is because obviously data in this area is really tricky, and also it feels quite uncomfortable. Nobody really likes labels, but actually without some kind of definitions of things, it's really hard to then kind of advocate and truly describe what we're talking about. So I use this one, which I think has they did more work into understanding why lots of women were hidden from previous definitions of severe and multiple disadvantage. And, you know, there is very detailed work out there, but the kind of short answer is that they then included being a victim of domestic violence and abuse and poor mental health as primary disadvantages. And so when you kind of include that into those 4 disadvantages, suddenly you find where all the women are. So this accounts for just over 5% of the population who've experienced 2 out of 4 of these black circles. By all means, we know these different forms of disadvantage are often intersecting and can be intersecting. It's not that anyone has to experience all of them, but obviously people have very unique experiences of multiple issues. Disadvantage to lots of people can sound really disempowering, and again, it's sort of the best I've found of a bad bunch of labels, in that obviously terms like complex needs and that sort of thing sort of imply that it's put the onus on the individual, which when we know there's so much structural inequality, we know not to be the case. So there's a very high health need for people with severe multiple disadvantage. So this is actually the data from the Inclusion Health work. So there's 8 times the mortality of men and 12 times the mortality for women, and 6 to 8 times the rates of disability. And we know that when we kind of look at homeless hostel populations, and the multi-morbidity and frailty is equivalent to greater than 85-year-olds. So already lots of health needs. And to kind of directly kind of reference gender and inclusion health, so Aldridge and colleagues who did this work a few years ago, and they looked at the different kind of inclusion health groups, and they found, of course, extreme health inequities across a wide range of conditions, but with the relative effect of exclusion being greater in female individuals than male individuals. So there's something that is particularly toxic about being from an inclusion health group and being a woman, that affects people's morbidity, mortality and sort of chances. And that's where the kind of data about it, you know, there being a much, well, it's appalling in both groups, and we obviously don't have other data on different genders, but there does seem to be a heightened impact on women. And we knew that sex workers were the least well investigated of all the inclusion health groups, and there are, of course, complex reasons behind that, but it's not okay to just accept it, really. So in Bristol, at the last count, which was now quite a long time ago, there were 146 street sex workers in Bristol. And when they were asked about their experiences, then almost all of them were abused as children. So these are the street sex workers who are Access 125. 99% were addicted to drugs or alcohol. 92% were malnourished. a third of the population were raised in care, 80% had experienced homelessness, and 15% had been in prison. So, you know, any one of these issues can have really profound impact on people's kind of traumatic experiences and health. Obviously, experiencing combinations of these can be extremely damaging, and people are carrying a lot and surviving a lot. This is a cycle. There's again from some work in Bristol where they did some interviews with street sex workers, and the researcher kind of coined this work, score, use cycle. So describing in the street sex workers this kind of exhausting and very time consuming and very traumatic cycle where people were, you know, often had addictions to fund, so they might work and they might also have pressure to fund their partner's drug use, and in the street sex work they might experience violence. They obviously have health risks, and it can of course carry psychological trauma. And then there was kind of scoring and getting drugs from a dealer, and that obviously involved other impacts on health, and then using drugs, which of course has other impacts on health, and kind of in that cycle, which I think, you know, I think doesn't completely resonate with my experience over time. I feel like I would be shouting trauma a lot more around that diagram, but yeah, I can see the kind of point that once people are kind of can be kind of trapped in this cycle. In terms of their health needs, when researchers interviewed 71 Bristol street sex workers, half had a partner, and half of these partners influenced the amounts they worked either through violence or manipulation. None were trying to conceive, but 71% didn't use any contraception. They were very hidden homeless, so they were staying in B&Bs or on floors or in a homeless hostel, crack houses, sleeping rough, or staying with clients. And 2/3 had children, but the majority had been removed from their care, which was just a huge source of trauma. Also mapping out the health needs, then this piece, they kind of compared women, kind of age-matched women from the kind of general population, and found that so at the top, if you've got any kind of long-standing illness or disability, like 100% of the patient, the population that were interviewed who were street sex workers had some form of long-standing illness and disability, compared to 22% of the normal population. And this just highlights some of the varied diagnoses and things that people were having to manage, and also I think really highlights something that can really get my goat, where there is specialist provision for sex workers. Often I find it's only sexual health. Very often there's not any specialist provision, but it seems like that's the one thing that gets offered, and actually a huge proportion of people's ill health is, you know, sexual health is important, but also other aspects of health are important also. And I think it sort of feels really like, is that saying that sex worker, it's only important to look after sex workers' health because of what they might pass on to other people, or what's going on behind that, what values, or like, does that come from the kind of historical kind of HIV movement, or I don't know. But regardless of where it's come from, sex workers should be entitled to comprehensive healthcare, as is everyone else. So in terms of people's experiences of health services, 83% were registered with a GP, 62% had not disclosed that they were sex workers. I think it's probably far higher, but I think because this is Bristol, I think they might be talking about having told maybe the GP at 125, which at this time wasn't me. 80% reported it was difficult to access a GP. Less than half had had STI screening in the past year, and 18% had never been screened. And only one was up to date with cervical smears. There's a high number of inpatient episodes and high obstetric risk, so often people are presenting late to kind of antenatal care. And lots of what this says to me is that the way that health services are being delivered and the relationships that are offered aren't working for sex workers. So they're either accessing care late or through the kind of wrong routes if they're going to inpatient, when actually maybe there could be more preventative stuff. And that's not, I'm not putting the blame on that to sex workers. I think we really need to listen to that as health services and say, even in Bristol, where there is enhanced access compared to other areas, we've got this wildly not good enough. So in terms of access to general practice, this is some work that I did, kind of a national survey, because I was kind of thinking when I was doing the clinic, like, you know, maybe in other areas things are, you know, people might be doing things differently and things are working well or not so well, and, you know, let's try and pool some of the knowledge because you know, in efforts to try and understand what works and that sort of thing. So firstly, at the top, looking at mainstream general practice. So this was surveys to anyone who worked closely with street sex workers. So it might be like caseworkers, support workers, drugs workers. I think we even had a paramedic. I think we had some police. I think, you know, so I was interested in what sector you were from or what your role was. I think we even had a priest or something. But I was more interested in that you actually had a really close relationship and you saw people regularly. Because if you ask healthcare services, then obviously the ones they see, they think, oh, we do all this stuff. But I feel like the support workers often see the behind the scenes, what doesn't get seen. So in terms of mainstream general practices, so we had 50 respondents. There's two questions: how accessible is mainstream general practice to sex workers, street sex workers in your area, and how well do you feel this meets their needs? So in the first question, about 50, you know, it was fairly split between people saying, oh, it's mostly accessible or mostly inaccessible. But as soon as you step that up to how well do you feel it meets their needs, then, you know, it's very strongly it doesn't, you know, current provision doesn't adequately meet their needs. I also asked about homeless health services because, of course, they are models that are available in some cities, and I wondered how well that worked for street sex workers potentially in other areas. And in terms of accessibility, it scored much better than mainstream general practice. But in terms of how well it met their needs, for some well, for some adequately, and for still quite a significant proportion not adequately meeting their needs. And some of the reasoning behind not adequately meeting their needs, the most common thing was that either the waiting space or the kind of run up to homeless health services often wasn't safe for street sex workers. So often people said that it wasn't a safe place for them to access care, not because of the service per se, but from, you know, it being targeted by perpetrators and dealers. And then I asked about other general practice, e.g. outreach, wondering if there was sort of any other people like me out there doing different things differently. And the largest proportion was, I don't think this is available in my area, but there were pockets where they were doing things slightly differently. And so it was interesting to learn from them. And like I said, with mainstream general practice, these are a couple of quotes. So one of the charity managers said, it's technically accessible and there is some awareness of the barriers to accessing services faced by women in prostitution, but there's patchy implementation of good practice which can facilitate access. So we did find examples where somebody were like, oh yeah, as I've quoted there, I have an arrangement with a GP as one of the practice partners to fast track street sex workers for access to healthcare. I'm able to accompany them to their appointments. So there were like little pockets where people had worked something out more often because they knew somebody, or they had, you know, they knew somebody was kind of interested in it and supportive, and people were trying to make workarounds to make this work, rather than it being sort of structurally supported throughout the board. Yeah, this fella who I always think, Julian Tudor-Hart, who I always think looks a bit like Captain Birdseye, coined the very important concept that the availability of good medical care tends to vary inversely with the need for the population served. So access to health for street sex workers is just a shiningly, terrifyingly strong example of this, where the people who most need medical care are least likely to receive it. And then we also hear about person-centered care, which sounds like a really important thing to strive for, but when you kind of consider at the middle somebody who might be street sex working or at risk of it, and the various other things that they may or may not be experiencing or have experienced, and then there's kind of one service maybe about your homelessness or your substance misuse, and then there's one service over here, like I don't know about in other areas, but any access to kind of trauma work, psychological treatments is so far removed from even people who aren't experiencing all of this that it seems like a pipe dream, which is devastating. And then there's another service for domestic violence, and you know, and so when these are all dotted around, and you're trying to experience, and you're trying to manage all of these things, and potentially doing this kind of work, school, use cycle, is it any wonder that we're not adequately supporting people? So the same researchers also asked the women, what would you suggest? How do we do this better? And they asked for all sorts of like really outrageous things, like, oh, I don't know, just put it in one place and give us some condoms and make it a convenient location, and if I could have showers. So this is we've got strong justification for the kind of drop-in model and having it all in one space. So really sadly, and I wasn't sure what to say, but I think some more to say, but the 125 has had to make some very tough decisions funding wise, and they have had to cut both their drop-in centre and their Move On project for street sex workers, which is awful. And I think we're all in a process of shock and trying to work out how to minimise harm, but it just feels completely devastating. And when I badger on doing research, and then the things that we know to be important then get cut, then it's a real challenge to kind of move forward with that. But move forward we must. So yeah, that is the drop-in centre, which will no longer run as a drop-in centre, but they are still going to have caseworkers. So women who street sex work in Bristol will still potentially have a caseworker who works with them, potentially one-on-one, and managing things that way. They are still continuing to do their van outreach, and so that's kind of where 125 started. So the van goes out, I think, 7 nights a week now, and it's just a recognisable van, because it's historically was all yellow, and then they got a new van that wasn't yellow, but they stuck a bit of yellow on, so everyone still knows it's the 125 van. You can get on, have a cup of tea, have some food, just have a sit and speak to nice people for a bit, and be signposted to various things if you want to talk about those sorts of things. And that van has saved I don't know how many lives. So this is what I used to do. Now it's been taken over by another GP, which is great, so I can focus on my PhD. But when I started the clinic, because it's such a tiny little room, I was like, I'm like Doctor Who, my little TARDIS. But actually, I was much more like this. So you really have to just offer what people like, be like, this is what I've got, what's important to you? Because trying to just barge in with your own agenda of like, oh, well, we need to sort out your Hep C, or we need to sort out this, or we need to do your screening. You really had to. It's for when when control and agency is taken out of people's lives so often, giving some of that back was hugely important, both for building trust and for building relationships. So yes, I was largely just like, this is the offering. How are you doing? What's important to you? And then I shut up and listen. We go from there. So again, this is from the survey, and I asked the participants about what they thought was important for health professionals and staff who are trying to provide healthcare services for street sex workers. And they said it needs to be trauma informed, they need to be knowledgeable on substance misuse, mental health, domestic violence, homelessness. Non-judgmental was probably top of the list, actually. Provide continuity of care for trusted relationships. So it really mattered that people stuck around. So this is why I've latched onto this old tree metaphor, because the people who stuck, like, there was definitely some women I supported that it must have taken 2 years to gain their trust. Like, if you can't, and I was incredibly protective over who would cover my holidays and stuff like it. You can't just, trust was hugely important, and just sticking around counted for so much. But also, I like this tree because it's got something propping it up, and I think that's important. So recognizing that we need to better work out how to psychologically support people who are working with this level of trauma, because I think I learned a lot from 125 and the way they worked and do it, and it's certainly something that's I haven't learned from the health service, and it's very much not a kind of endemic in a kind of NHS culture. But I think there are efforts to shift that, and I think that's hugely important. So bridging gaps came from discussions in about 2019, May-ish, I think we started it, where we were kind of recognising that people with severe multiple disadvantage had really high health needs and often had really bad experiences of authority, but yet poor access to general practice. But then on the other side, you could see, I could see working in general practice, there's often really caring staff who want to help, but come from very different backgrounds and experiences, have a very huge workload, maybe working from limited information, and often have a lot of time pressure. And I found that, like, increasingly, the more strained general practice seems to be, the more savings we make by kind of relying on people's individual resources, which, can't, which surely just widens inequalities further, because it works for people with lots of individual resources, but not for others. So Bridging Gaps is a co-production project of women with lived experience of street sex work and all the other kind of severe multiple disadvantage factors I was describing. A support worker who has worked closely with them for years, myself, and another researcher from the university, and we've collaborated with a number of local general practices to just say, look, these are some of the issues, let's discuss how can we do this differently. And we're not kind of doing it in a, hey, you naughty GPs, let's tell you how to do it. Like, it's been very much a kind of two-way sharing of experiences, and we've done a lot of changes, and quite a lot of those changes have stayed, which is cool. So 2 of the practices that we work with have used care coordinator funding. So they have a full-time care coordinator who is focused on inclusion health groups and is proactively inviting people into the surgery and giving them reminders for their appointments. And there's often kind of clinician consistency. So one of the surgeries has this specific, like, open doors clinic where it's longer appointments. It's with 2 GPs who've got experience in homeless health. So it's kind of trying to blur those sharp cliffs between services really, and try and make that better. And we've definitely improved communication pathways between agencies. We've won some prizes. I've got 2 papers about to come out, so keep your eyes peeled. One is on trauma-informed care and co-production. So co-production is gaining momentum, and it's all very exciting. But when you look at kind of co-production principles, there's a few kind of omissions in terms of actually if you're working with people who've experienced extensive trauma. So we've been trying to contribute to that literature, be like, this is how we've managed to co-produce with people with extensive trauma, and that's been co-authored by our team. And the second paper is on some of the findings that we've developed with working with general practices, so how we've improved access for people with severe and multiple disadvantage. I'm not going to go in detail through them, but that table will be in the paper and it will be in the presentation. I just don't want to go over. And bridging gaps, we've got exciting new future direction. So because I've stepped back a little bit I'm doing my PhD, which is the connection study. So I'm still very much working with them when they're kind of working with surgeries and more existing collaborations, but it's quite exciting. They're becoming a bit more kind of independent and autonomous as a group. There is going to have to be a bit of a shift in collaboration with 125 because of all the surface changes. We can't really be supported in the same way, so we've got to work that out, but we will. And this is a bit about my PhD. So it's all focused on improving access to general practice people with severe and multiple disadvantage. Bridging gaps are my sort of PPI group, but I want it to be much more meaningful than just PPI, or very good PPI. And so it's kind of complex intervention development, and I'll happily yabber on about that to anyone who's interested. But top tips generally start with their agenda, not yours. And this came from, this is collaborative, like my experience plus from the Bridging Gaps team. Go steady, slow progress is better than no progress. If you try and push people through a bazillion things, they might just not come back. So the relationship is the most important thing. Listen, don't judge, be flexible. Clinically, in terms of like managing risk, it can be really tricky because you're working from a lot less information. Often in an ideal world in a hospital, you'd have a bazillion tests and investigations that would help you answer it, but often people aren't willing to go to hospital, and you're having to make decisions on the balance of risk. So I find myself really often having to go into those realms of like, okay, does somebody have the capacity to make this decision? Do they fully understand pros and cons here? And I'm going to respect that. And let's come up with a plan together on the balance of risk that you are okay with. And look after yourself and colleagues because it can be really hard. And that's it. Thank you very much.
Thank you so much, Lucy. I feel like you've just done like all of our med school inclusion health teaching in like one lecture really fast, so thank you. And it was just really nice to see how you're doing action research as well. Like I feel like we hear a lot about research, but seeing that being put into action, and hopefully the 125 drop-in will be revived. Hopefully. But thank you so much for your time. And if anyone has any questions as well, please put them in the chat, but we'll probably do the Q&A at the end. And now I'll hand it over to Denver and Jason, who we're very lucky to have speaking with us today. And they're both from Spectra, which is a London-based organisation that focuses on sexual health and emotional well-being for people of all sexualities, all genders, all cultures and ethnicities, a very welcoming space. And so we're very lucky to hear you both talk, and I'll hand it over to you if that's okay. Would you like me to share slides, or would you be happy to share slides, Denver or Jason?
I can do that.
Cool.
Can Can everyone see that okay?
Yeah, we can see them.
Fantastic. Just a quick clarification. Sorry, I wasn't super clear in the emails. So while I'm with Spectra, Jason and I know each other through lots of different grassroots projects that we've worked on together. So just to clarify. But yeah, so welcome to Sex Workers. This is Access to Health and Wellbeing Services. My name is Denver. My pronouns are they and she. And just a little bit of history about my background. I have been in the sex industry in various forms for about 13 years, doing full service in-person sex work indoors, independently, doing porn, doing fetish work, doing webcamming, in and out throughout the years. And I facilitated the Sex Worker Breakfast in East London up until I got this role at Spectra, where I'm the new lead for the Sex Worker Support Service.
And I'm Jason Domino. So my background, well, I'm Jason Domino, he, him, and my background similar. I have sort of in industry experience as well. So my background's come from gay porn. It's also come from full service work, or what's often quite commonly in the gay scene just referred to as escorting. But again, different spaces have different terminology. We'll kind of dip into some of that later and how that can present barriers. And then sort of outside of specifically that industry, I then went on to work at National Ugly Mugs and have done quite a lot of work in the HIV activism through porn and amongst the community, and just got back from a conference amongst sex workers of different types to spread sexual health information there as well. That is a little bit. We want to know about saying how we started. I think like most people, I started because I needed the money, and I'm quite a neurodivergent person, and I was getting extra barriers for more traditional forms of employment, and it seemed to work quite well for me. So yeah, that's me.
And just before we begin, Jason and I thought it'd be really important just to manage the expectations of what we're going to talk about. So while Dr. Potter's obviously given a really in-depth insight into street sex workers, we wanted to talk a bit more generally and give more of an overview, and really show how there is so much nuance and so much diversity within sex work, that if we were to even attempt to give more of a closer look at any of these aspects, we think would be doing our community a bit of a disservice, because you would go away thinking you had an understanding with just the briefest of surfaces of had been scratched. And Jason?
Oh, I'm not seeing the next slide pop up.
Oh.
Um,
Oh, hang on, sorry, it's just gone back. There we go. Sorry, technology.
Okay, but I still can't see it, but I'll do it anyway. So some trigger warnings. We've covered a lot of subjects in the previous presentation already, but obviously there's going to be substance use, racism, sexual assault, violence, queer phobias, sexism, identity crises, potential conversation about suicide. So there's a number of different things, and if that's going to be a difficult thing, then maybe circle around to come have a look at the rest of the talk later on when that's easier time for you to look at that. I'm not quite sure why my preview is not updating, but let me know when you want me to do my slide and I'll do it.
Sure, I will do. So first off, what is a sex worker? It is an umbrella term. So a little bit of a quick history lesson. The term sex worker was created in the late 80s with the sex worker rights movement for people engaging in prostitution to essentially shield themselves from stigma by including themselves with strippers and with porn performers. So a lot of services and a lot of researchers use the term sex worker when they actually mean prostitute, someone who is just doing full service sex work, and sort of ignores the whole reason the term was made. So sex work includes obviously full service in-person escorting, street work, indoor, outdoor brothels, porn performers, webcamming, but it also includes strippers, it includes sugar babies, it includes go-go dancers, it includes erotic masseurs. Anything in that industry, it comes under the umbrella. And another thing that frequently isn't acknowledged is how not everyone identifies as a sex worker. Especially in the queer community, sex work can be a lot more incidental. It can be a lot more casual. It can be on Grindr, and you accept money for sex when you're offered. Not everyone necessarily thinks of themselves as a sex worker. A lot of people try and distance themselves from the term, especially in terms of pro-doms, a lot of the fetish community, a lot of porn performers want to think of themselves as adult performers or adult entertainers rather than sex worker. So definitions are important. It's really, really important to talk very clearly about who you're including when you're talking about sex workers. And sex work as well, not everyone does just one kind of sex work. People move in and out and between types of work depending on their circumstances and what they have access to. Both Jason and I have done lots of different kinds of sex work. When I started webcamming, that was during COVID, because it was illegal for me to see clients in person. And I know many other indoor escorts who moved online, who set up OnlyFans, who started producing content because there wasn't any ability to do the work that they had done before. We also saw that during COVID, street workers moved indoors and did find spaces to work indoors because they had to, because again, it would have been illegal for them to be visibly meeting people outside. And the cost of living crisis means that more people than ever are returning to sex work. It's often something that you move in and out of depending on how much money you're making at the time, whether or not you have got someone that you need to care for, if you have developed an illness. All of these things contribute to what sex work you do, how long you do it for, how many different multiple income streams you have going on at once.
And just before we speak on intersectionality in sex work, just because Denver just covered really well why a lot of different sex workers might not even use the term sex worker, have a think about that when it comes to sex worker specific clinics and material, and who will pick up that piece of information when it's particularly targeted at certain communities that may not use that term at all. So how does that affect the data that is studied? We'll come up a bit more into that later on, as well as issues like toxic masculinity and things which might prevent certain people approaching support in itself. So intersectionality includes...
Jason, sorry, I'm so sorry. I don't know whether we can't see the slides moving. I don't know whether you want me to try share it at all, or if you're happy to carry on. Oh, I can see it now.
It seems to move that, like, okay.
Can everyone else see it?
Yeah. Is that okay for you to do the slides, Denver? I think your control.
Yeah, no, it's sorry, I'm such a troglodyte.
Not at all, not at all. Okay, great. So intersectionality, and I think Lucy did a fantastic job in the previous presentation, just highlighting how many different types of communities are involved, where even if obviously looking at the street-based sex worker, you get the same sort of dynamics across the whole wider sex worker spectrum, where there's frequent occurrences of people being neurodivergent, frequently people being queer. There's mixtures of different racial of ethnicities and different sort of backgrounds, and so there's a whole load of different factors that sometimes impact one another. Something that I like to reflect on within this is, a moment ago I talked about toxic masculinity briefly. And I would say that the impact of something like toxic masculinity would mean that that common idea of boys don't cry as a message, right? It might mean that people who are masculine people within the space or identify in that way might feel less likely to, again, engage with services or be open about something that they may see as some sort of weakness. So there is an enormous space where understanding the intersectionality can always increase. I've just come from a large conference where there have been hundreds of performers, and they would many of them call themselves porn performers, gay porn performers, and most of them do in-person escorting as well. And it's one thing that sort of helps the other. And so a lot of them have never come to sex worker specific clinics or engaged with research. So again, there's a lot more that can be understood with this. And understanding with that means that we are able to understand how much financial need is sort of like core reasons, but understanding also where there are other factors. Again, Lucy mentioned trauma. I think that's incredibly important. The more research that goes on with, and as I've mentioned already a few times, neurodivergency. How much are these elements playing a role with the fact that they are working in sex work? We are working on sex work currently. Yeah, and I would say that many of those things are left unaddressed when people try to say, let's help sex workers out of the industry or something like that. So that really doesn't help any sort of work transitioning. Last thing I'm going to say on this is that really important when doing engagement with migrants and communities where there are extra language barriers, that there are appropriate measures put in place to try and speak to the communities within languages that are right for them. That they're more comfortable with. End of my slide.
So I think one of the biggest issues that we see so regularly when we're talking to professionals in services, in wellbeing charities, in support networks, is how there is an assumption that stigma is just something that makes us feel bad. It hurts our feelings. It makes our day that little bit much worse. And while of course that's true, stigma is very, very dangerous. Sex workers are not identifying themselves to services, and it's really understandable when you start looking at the potential outcomes of that. You don't know who you're sharing information to. You don't know who they're going to gossip with. You don't know which authorities, which other services they're going to share that information with. You don't know how long that's going to stay on your record. If you out yourself to the wrong person, it leads to situations where you could be misdiagnosed, you could be undiagnosed, you could be discharged from, or you could be refused medical care. You could be unable to access your money if you've had your banking and payment accounts shut down. Many sex workers do sex work alongside a respectable job. I have pretty much always had a full-time job as well as doing sex work that hasn't paid me enough to meet my needs, to be able to pay my bills, to be able to pay for therapy and things like that. And so many contracts still have morality clauses. It's very, very difficult to feel safe outing yourself to somebody if that might lead to you having to rely on sex work full time instead of just part time. The way that the media speaks about us is not just harmful, it's not just horrible to read, but it also leads to things like having naked pictures of yourself printed alongside our legal names, the risks from that. It could lead to us being banned from entering other countries. Last year I got married and my wife and I would love to go to New York, but because I am a face out sex worker and I have been for some time, I've given my passport to many sites, and there is a high chance that my information has been given to border control, and that if I attempt to access America, I won't be let in the country for the next 10 years. Things like stigma and outing mean that we are subject to harassment and abuse and violence from not just clients, but from our own intimate relationships, from our community, from our family members. We can be evicted or forced from our homes by our landlords and our roommates and our partners. We can be chucked out. Sex work is something that people do not just when they hit rock bottom and they have nowhere else to turn, but it's also a safety net that people do in order to stop themselves from becoming homeless. When your rent goes up, when you lose your job, when there are suddenly more money going out than you have coming in, it's something that you do. But at the same time, it's something that if your landlord finds out that you're doing it, even if you're not seeing clients at home, they will often evict you to keep themselves safe. Sex work means that we are separated from our children by social services and courts. It means we get visited by police, we get arrested, we get charged, we get victimized by police themselves. They are often our clients one day and criminalizing us the next. They assault us, they abuse us, they blackmail us. We get raided at our workplaces. If you're a sex worker in a brothel or any other kind of venue that you're sharing with another sex worker, police can storm in and record you on body cams. They can search you in your underwear. They take your earnings. They confiscate any money that you've made as the proceeds of crime. And they shut down your workplace and they leave you without a job, as well as your colleagues. And of course, sex work can get you deported. It's not recognised as a valid form of labour by the state. If you're a migrant sex worker, you're likely doing sex work because you don't have the right to work in the UK. But again, it's a thing that can get you kicked out. And it's really important to remember that this is not just something that street sex workers face. No matter where you are in the industry, no matter what type of work you're doing, no matter how happy you feel you are, no matter how safe you are, no matter how much money you're making, how many friends you have, how empowered you feel by your work, you face all of these risks, and there is no way of knowing who is a safe person to talk to and who isn't. I really want to point out that Jason and I are both white British citizens. We're well spoken, our disabilities are invisible, we pass as cisgender people. All of those things give us privilege and they give us safety. That means that we're able to be here speaking to you with our faces out, with our real names. It meant that I was able to get this job at Spectra. All of these barriers in place keep us safe. And that means that the people that we know are sex workers are the ones for whom it's most safe to be out. Isn't?
Okay, so now we're going to look into what often the community calls hierarchy, which again sometimes is also called sex worker elitism. So we talked a moment ago about the sort of different parts of this spectrum way of thinking of looking at sex work, but the attitudes amongst the community when there is a sort of hierarchy forming can mean that there's a breakdown in peer-to-peer support. However, in different parts of this spectrum, there are different needs that are needing to be met. So if we're looking for a moment at, let's look at porn for a moment, which is frequently considered one of the sort of lower risk parts of the sex worker spectrum, because perhaps earning is happening, particularly if they are somehow involved with maybe content creation, so that there's an earning that's coming in from a singular piece of contact. When we're looking at something like that, there is still issues when it comes to if they're wanting to get maybe test certificates so that they can film together, which is somewhat done a little bit more with studio porn. Where are they going to get these certificates? Do they know about the certificates, which are sort of a printout with their like ID scene sort of thing written on their STI results? And if they ask for this, our clinic's going to charge them. Even in London, it varies as a postcode lottery where you can be charged £70 just to get the certificate. There are places further up across the country which charge a lot more. There are many people who will travel as far as from Scotland to particular clinics that they know in London and other places where they know that they are providing them for free, because they don't view sex workers as like a piggy bank to charge for those services for. And that extra traveling, particularly during times like the COVID, meant there was a lot more people exposed to extra risks, and the general sort of like displacement of people meant that it wasn't particularly a safe thing for them to be doing, particularly when it comes to a mixing amongst the community. Well, I want to rephrase that, because that sounds like it's about the stigma of being a sex worker, but I feel like what I mean is when sex workers engage with particularly new clinics, they don't necessarily form this sort of trust, because they are on the edge of whether our ID is going to be, whether our account on that particular clinic is going to have sex worker written next to it, and whether that will mean whether we come in for something else, we're going to have delays because we're going to have people saying, oh, have you done this, have you done that? There's multiple sex workers I know who've had PrEP sort of quite aggressively sort of encouraged for them almost every time they go to the clinic, and then they haven't been in a place where they've been sort of receptive to trying new medication because of some like difficult past experiences. So these experiences when you go to a new clinic can be really daunting. I'm going to move on in a moment. Actually, yeah, but that's some of the, so it shows you how the high end, like, or the low risk parts of the spectrum can actually transition so that people actually become the higher risk parts of the community. People who are maybe sex workers who are living with HIV may struggle to get work within things like porn industry and might find it easier to have work within a brothel setting. That's quite a common story. So again, the flow as a wider network, as a wider economy, is a shift that's a really helpful way to look at it. Over to you, Dana.
So we have to remember that sex workers engaging with services is all based around the services themselves, which are based on the research that's done. But there's a lot of problems with the research. A lot of it is very, very dated. The amount of times that I will see, there's a particular Office of National Statistics study from 2004. I have a lot of issues with the methodology in general, but one of the most important things, that's 2004. That is a very long time ago compared to how much the industry has changed. It doesn't take into account the way that the internet has impacted the way that people work and the type of work that people do. And again, it's really difficult to know how many sex workers are there because being out is really dangerous. We find as well that services often use websites that we use to advertise on to try and get an idea of the number of sex workers or the demographics. One of the biggest problems with that is that marketing is not real life. These are advertisements. They are there to either make us more money or to keep us safe. Those are the two main reasons. I know a lot of sex workers who don't share their assigned gender at birth because they don't want to put themselves at risk of transphobic violence. I don't think I know a single Muslim sex worker who says that they're a Muslim. I know a lot of Romanian sex workers who say that they're another ethnicity because of xenophobia. And again, this is something that circumstances will have an impact on. For instance, Brexit has obviously had a big impact on how brave people feel to be racist. There was a needs assessment recently which relied on adverts to get an idea of the number of sex workers in an area. The first problem was that they used two websites, Adult Work and Viva Street, which are generally used by cishet people, cishet women, or people who work as them. They didn't look at anything like Sleepy Boy, which is a website that's much more commonly used by gay men and trans sex workers. So, of course, the 100 or so sex workers they found in this area were 99 cis women. But they didn't realise because they haven't used these websites themselves. And I noticed because I have used this website to work, to advertise from. The method of counting up the sex workers was something called the local escort search. And you wouldn't know this because it's not obvious on the front end. Why would the clients, the customers using the site need to know this? But that's a paid feature. And when I did a proximity search instead, which isn't a paid feature, that just shows everyone within X miles of a certain location. And instead of 100 sex workers, 500 profiles came up. And even accounting for the fact that, yeah, a lot of them are going to be duplicates, a lot of them are going to be dead, some of them might just be random catfish accounts, some of them might be nosy journalists. That's still going to be around 80% of people who aren't included. And who are the ones who aren't paying for advertising? They're probably going to be the ones who can't afford to do that. Or there's going to be other factors in there. So this shows how not having sex workers being involved in the research from the very top means that you lose all of the context, all of the understanding, all of the cultural references, all of the slang terms that we use that give you this really thorough understanding, which means that the most marginalised groups of us can be identified and they can be recognised, and services can be built for us as well.
Okay. Just because I'm aware timing wise it's going to be tight soon, I'm going to cover things a little bit faster now. But so where's everyone going? Basically, if our research isn't capturing everyone and not everyone is feeling comfortable going to spaces like clinics, then where is everyone getting their help? They're not trusting these spaces. Well, again, as two people from the community, we can confirm from our own experiences, at least, that a lot of us are engaging in sort of peer-to-peer self-organizing. We're actually mutually helping one another. And you can find that was particularly a strong example of that when Swarm, a sort of sex worker-led organization, gave out, accepted donations and then gave out a hardship fund, a sort of mutual aid fund during COVID. And they ended up giving up 300,000 in individual like support donations to sex workers of around £200 a turn. And by doing that, they learned a few different ways that sex workers were more comfortable engaging with it, not having to sort of like means test, not having to sort of say, I deserve this test because I deserve this funding because of X, Y, and Z, but instead, actually, if someone is already within the community and they're saying, I'm going through a rough time, the fact that it's sort of self-selection was a really like important factor for these people, because there's already an element of trust about the people being in the community, and there's this comfort of not having to disclose some really perhaps traumas or difficult things that they're dealing with at the moment, including financial stresses or insecurity. There's a whole load of other different organizations. There's breakfast groups, there's a trade union which can help support sex workers when it comes to their legal rights. It's been very effective with strippers, but it's a very, very important tool for a whole range of different parts of the sex work spectrum. You see the community writing around books, you see the community doing protests on the street, not that they are necessarily very well covered in mainstream media, because of the nature of the way sex work is mainly presented in a sensationalist and sort of sexy way that can sell for an end user rather than actually what our voices are saying about our rights. So there's all of that sort of barrier there. Even if you look at the government website and you search for sex work, you'll find two very small sections on it. And most of that is a very limited amount of, let me just double check exactly what.
It's on the Inclusion Health page, which lists the inclusion health groups and all of their different needs.
Amazing, thank you. In fact, I'm going to hand over again because timing wise. Okay, so the main takeaways that I've got to encourage people with is to educate yourself as far as find out where your small, well, not small, but your peer-to-peer sex worker organizations are. Find out the names. You'll be able to find them with not too much digging, because we've actually been being quite loud about like the groups that are out there. So have a little hunt and we can maybe chat a bit more about them in the Q&A.
Second of all, engage with us. So follow us on social media, read our blogs, listen to our shows, listen to our voices and listen to our stories, because we talk about the things that we go through and also our friends and our families and our community members. It's really difficult to get an understanding of the difficulties we face if you're just looking at research. You need to absorb what we're saying on a day-to-day basis to start noticing the patterns. And it means that if you can't find what you're looking for, you can ask us and we can point you in the right direction. And you can invite us along to things like this, to your networks and your conferences and your projects, and have us contribute.
So enable us is going to be the next thing that I'm going to cover. And I say a really good example of this is something like when a sex worker clinic actually takes the stand for something like the decriminalization of sex work for the sort of harm reduction benefits that it poses, the community listens to one another about how much more we trust that particular clinic. And if you're looking for engagement rates and you're actually going to be moving forward to be involved with these sorts of clinics, you can actually look at it as a really effective way of engagement with the community, because what we're working on, actually there's a relationship with your engagement rates.
And finally, embrace us. So yeah, invite us to things, tell us about bursary tickets. We're not looking for them by ourselves, because we are focused on helping our community members meet their immediate material needs. It's really difficult to prioritize attending events and talking and contributing to research for free if we're all ourselves doing sex work out of financial need. We're going to prioritize ourselves and our community members over something that might have an impact 5-10 years down the line. Use your own privileges, use your platforms, use your clout to amplify our voices and open doors for us. You can protect us from criminalisation, you can help us stay anonymous, and you can help us find ways for us to bring the voices of the people who are being ignored time and time again, who it's not safe to come out. We talk to them, we have very open discussions and honest conversations with them. And we can bring those experiences to the forefront. And with your support, you can sponsor funding applications, you can volunteer, you can share training, you can employ us, you can recruit us. We are experts. And if you're calling us experts by experience, you've got to pay us like experts as well. It's not doing us a favor to act as though we should be grateful to be given the opportunity to volunteer our time for free. We're specialists, we're cultural guides, we have so many skills and so much knowledge and so much understanding, and we can walk you through things, and we have networks, we have connections that are valuable that you would never have access to otherwise. Sorry, we've overrun a little bit, but yeah, thank you very, very much for listening, and we hope that this has inspired you to start digging a bit deeper and changing things a bit. My name is Denver, my email address is there if you want to get in touch.
I'm Jason, and my email's on screen there as well. Thank you very much.
How do I stop sharing the screen? There we go.
It's a round of applause from Teams. Thank you both so much. Like, bit speechless, but I'm also like, you, by sharing your story, but then also bringing perspectives of intersectionality and information that we as healthcare students might never ever get in our careers, really, and telling us go do the work, like go actually like do something after this, was very, very important for us to hear. So thank you so much. And if you have any links or like places where you think that we should go look for or start for looking for information, we'd really appreciate that, and we can disseminate that to the rest of the group as well. Because I know there's people from kind of all over the UK, so hopefully we can find peer-to-peer organized groups wherever everyone is in the world. But it's also we're running a little bit over, so I don't know how people are feeling for time in terms of Q&A. Oh, Jason's put some good stuff in the chat. Are there any burning questions at all? I don't know, Lucy or Denver and Jason, are you guys okay to stay on for like another 5 minutes just to see if anyone's got, thank you, got some questions?
Yeah, I had one. I want to say thank you as well for sharing some like really real accounts. And like Dan was saying, it's something that we probably wouldn't ever really get in our education. So really thank you for sharing those with us. But I think it was really clear to me like how much you were saying stigma is just so perverse, and it's so like diffuse in every aspect, and like can act as a barrier, whether that's felt stigma or an enacted stigma. And I don't know where you think, I don't know if it's too big of a question to think where do we begin to like tackle that? How do we reduce this stigma and make people feel comfortable to disclose whether they're sex workers or not? and provide that care or those services. Yeah, I just wanted to understand where you think we start with that, or if it's too big of a question as well.
So I think that one of the easiest ways to make people feel safe disclosing that they're a sex worker is don't make them give their legal name. Give them spaces where they can disclose this to you that is completely separate, that they know isn't going to be attached to their NHS records, that isn't going to be given to anyone else. I mean, Denver is not my real name, even at Spectra. I am an out sex worker, so I keep my legal name completely separate and completely private, just because we don't know how the law is going to change down the line. We don't know, not just in the UK, but also in other countries. You can never predict the future and how the culture and the opinions of the general public and of healthcare professionals and of the authorities will change. So giving people as much choice and opportunity as possible to keep those things separate will at least allow people the space to feel like they can have that openness with you, I think.
I'm going to jump in and try and say that a really big way of tackling the stigma generally is listening to some of the decriminalisation sort of conversations. So decrimnow.org.uk goes into some of that really, really well. I've mentioned some different organisations in the chat, which are good places to sort of find out other organisations through. So there's plenty of documents there which can actually look at the impacts of stigma. However, we don't necessarily need to build structures where sex workers will be open to you about these things. You can enable sex workers to provide amongst one another to have the tools that they need to take care of ourselves. And it might be that that's a journey that happens as we feel less vulnerable with engagement with larger sort of spaces. But, there's options to look at that. I would say that there's real strengths for you moving in the next steps by saying, well, the community is asking for HPV vaccinations for sex workers. What are the barriers? What are the complications? What are the issues that are happening for this particular marginalized part of sex work? How are they getting treated? I'm going to be quiet now, but over to you.
I wanted to just add to that as well and say that, like, I think even just having conversations like this, where we're kind of just human to human going, oh, I think human can feel like they had to hide, but that's not going to be anytime soon. So, like some of the examples you've given, giving people control and agency over what they feel safe to share and different ways for them to do that. So I think often in healthcare there is this real like when I drop in clinic 125, I never had to directly ask people because I knew being the clinic that they were. I know also in my normal general practice role, I've certainly come across patients who I think I wouldn't be working, and I haven't directly asked them. I think it's a kind of case by case thing in terms of people's relationships. But I suppose even if that's a possibility, my importance is our relationship of care that you need. So I can still do of healthcare that we can, and the fact that people have that good relationship is probably the best way to access care appropriately. Whether their record is completely accurate as to all of their experiences is slightly, is secondary to the most important thing. But yeah, it does mean our data is rubbish. Oh, on that data question, I'm going to jump in with a question to you guys. So I put a link in the chat about the Sex Worker Research Hub, because something I really picked up on you saying was like, involve us in the research. That's how you'll work out things a lot better. And I completely agree with that sentiment. where I'm striving to collaborate between researchers and people with lived experience of sex work. And I think at the moment there's few and far between examples, but my hope is that we get better at that. But yeah, to certainly echo your point that we need to appropriately pay people for their time to contribute to this.
I've just that's sort of just made me think of another thing that we didn't really get time to expand upon is especially with having involvement in research of not just having that sort of tokenistic picking one person with lived experience, because Jason and I have very, very different experiences of sex work. Where our clients are different, the way we brand is different, our everything is very, very different, but we also have a lot of shared demographics, and there's so much diversity and so much difference within sex work that you can't just pick one person to sort of like review and consult on something. You need to have people from all aspects of the industry, from all different demographics, in order to ensure that it's something that can, is accessible for everyone, that the terminology is something that means the same to everyone. And that you're providing things that are a priority for enough people, because otherwise you'll just go off on the wrong track. Even I, after 13 years of doing sex work myself, my wedding had like 50 sex workers in it. I'm so surrounded constantly. But even at Spectra, writing the leaflets for our new service, I was constantly in my group chats running stuff by other workers, because I've never worked straight. I've never worked in a brothel. I've never worked in a strip club. So actually, from my lived experience, like, it is still narrow, it is still limited, and you've got to. I think we all just need to really recognise our own limitations of what understanding we have, what experiences we have, and what we can be an expert on, because there's lots that we can't be.
There's more that I can build off from that, but is there another question that you'd like us to move on to? I don't want to.
I'll ask if there are any more questions in the chat. There's nothing that's come up in the chat, but there's no one with their hand up, so you can carry on with your point, Jason.
Great. Okay. So I have worked in spaces like brothels, and sometimes that's presents its own challenges, because people don't necessarily even expect there to be gay brothels in existence, and the extra legal ramifications in their sort of workplaces can mean it's harder to be visible. But yeah, a lot of the different complications that come with this often come down to, again, as we've said a few times, painting as a spectrum, because I would mainly choose my sex worker clinic based on whether they would be able to provide me with something like the certificates I told you about before, which I would need for porn and things like that. But to begin with, I really wouldn't have identified or felt comfortable going to some of those spaces, and would have really sort of kept it quiet. When I've tried to encourage other people within the community to get involved, even with activism, I've had to do things like invent completely new words and say, you are, so one project I've worked with is called Banana Milkshake, and we say, you are a Banana Milkshake member if you are a content creator, a go-go, a stripper, something like that, so that you aren't necessarily, or if you are putting them into one particular label, it's something that doesn't have as much baggage. When it comes to websites or forms or projects you're doing yourself, maybe leaving spaces for people to be able to fill in what type of terminology they would like for the rest of your site to populate it in that way. It takes a little bit of innovation to be able to see if you're starting with the worker's experience and seeing if you're providing in the ways that flows for them, rather than is convenient for the project provider or research piece.
Thank you, Jason. I love the word banana milkshake. Oh, go on, Lucy.
Sorry, I'm aware we're over. I just can't help but use this opportunity to kind of ask, because as we've all acknowledged, like, the breadth of what sex worker means is so vast. because because I've worked with street sex workers, sometimes I'm asked for things like this where they're like, oh, you know about sex work. I'm like, well, I know about this bit of it, but like how like even, you know, sex workers being one of the inclusion health groups, like how useful or not useful do you think it is to have sex work as one group? And I don't know the answer, but I wonder on your thoughts on it.
I'm just checking who you're asking, whether it's a community for people to write into the chat, or whether you're asking one of other speakers.
I specifically the speakers, but interested in anyone else's opinions as well. But specifically, you guys.
Okay. Is it okay for me to go first, Denver? Okay, awesome. So I think it's incredibly useful because funding, we've seen, well, I'm so sorry to hear that your funding's been impacted. We saw the same sort of things within the HIV sector around sort of between 2014 and 18. It was sort of halved at one point, and loads of sex worker clinics were supported through HIV funding, and there was a radical reduction then. And so Inclusion Health, I think, challenges existing clinics to be better in their serving of people, and means that it also has ways of maybe even safeguarding some of that funding in ways where there are structures to be able to say you can't just axe this because it's one particular branch of where funding comes from. It removes that justification as a singular thing and makes it a little more secure. That's my thought. Oh, I guess so. So we didn't get COVID vaccinations access really as just sex worker groups. This is an example of why this is really, really helpful. But as an Inclusion Health sort of spectrum, it makes it easier to have the conversation, even though there is like an overlap of when we are potentially unwell because of something like COVID, then we're not earning our money, and so how are we going to pay rent? Maybe that, you know, fall into different parts of the Inclusion Health spectrum there.
Yeah, I think what Jason said about funding is really important because up until recently, frequently specialist services for sex workers have come under the VAWG sector, which, you know, are very, they have a very particular narrative and type of terminology that they use. So instead of sex worker, they, you know, use the term like prostituted woman. You know, it's not something, it's something that is done to you, which, you know, it inherently removes agency, and obviously it assumes that everyone who does sex work is a woman. And yeah, that can make it, you know, the terminology and language that they use, for me, even though that I haven't particularly enjoyed doing sex work, I mean, you know, no more or less than I've enjoyed working at a cinema, or but it meant that that language and terminology can be really dissuading, because even if I wanted to, even though I did want to reduce reliance on it at least, there is no way that I would have gone to one of those services when I have seen the, you know, just the really dehumanizing language and the way that I think a lot of them really rely on talking about sex work in like a very emotive way that almost feels like an act of violence in itself. It's very often really talking about very traumatic things and using this language that they take from like client review forums, and then they just sort of regurgitate it. And when you're like, whoa, hang on, that's actually, I don't like it when you're like, oh, you're just a bit of meat, oh, you're a whole. And then, you know, that's not very nice. That kind of feels a bit misogynist. The response is often along the lines of, well, this is just what your clients think of you. And it's like, okay, but it doesn't, I know that like, I know that that's what some of them do say, but they also give me money, so I can ignore that. Whereas you're not paying my bills, you're just being kind of rude. So I think that, yeah, that feeds into it a lot of, yeah, the way that, and yeah, I think that it feels like in terms of us being an Inclusion Health group, there isn't that much like that we get out of it yet, but I see so much opportunity. Like, I think it's really exciting. I think it's really positive. And it also recognizes it seems to sort of get across the intersectionality, and that just like homelessness, it can be, you know, it's not necessarily a scar that is sort of like stamped on you that stays with you for life. It can be, you know, state. You know, it can be a temporary thing that happens, and the way that all of the inclusion health groups, pretty much all of them, you know, feed into sex work, or all of those things make it more likely to be a sex worker. But then sex work feeds so much into homelessness. It's so difficult to get housing. So many people are in really, really bad housing situations where if you don't have proof of income, if you don't have a stable income, you can find it really, really difficult to get housing, especially if you are an indoor worker, if you want to be able to see clients where you live, if you want to live in an area where it's easiest to travel to where the clients are, you know, I guess this is going back to what I was saying earlier about the sort of mapping of how many sex workers are in what area. Sex workers travel everywhere all the time. Like, I've gone up to like Birmingham for a single booking before, because, you know, the money that I make for that, you know, as long as it covers my train and my time traveling, as you know, and
Same.
I'll
I've
put my
done Cardiff.
location. What was that, sorry?
Same for Cardiff, you know.
Yeah. So I think, yeah, having that understanding that, yeah, it is a lot more, it's a state that people move in and out of, and, you know, and people do it in different areas, and it's really hard to pin down, it's really hard to define, and even a lot of us don't know how to define it, a lot of us don't identify in these ways. But having it as a wider grouping within inclusion health means that there's a lot more freedom in terms of opportunities for being anonymous and having access to services and things like fast tracking, you know, just things that make services more accessible and more useful to us. It means that we can sort of hide in plain sight in the group of inclusion health. And it also means that when we're talking about things like vocational pathways for sex workers to reduce reliance on sex work and move into places like the health sector and the third sector, so that all of that knowledge can be shared and actually be of such good use, it means that you don't necessarily have to be out as a sex worker in those spaces. You can be part of a charity that helps people from any inclusion health group go into those, and you've got that plausible deniability. You know, it's not as, it doesn't mark you as much.
Thank you. Thanks, guys. Any more final thoughts, or are we happy to bring this to a close? I think we've had, thank you for going over like by half an hour for everyone who's still on the chat, and obviously especially our speakers, Chris, Jonathan as well, staying on the call. Thank you. This was, yeah, and everything you've said about I think what the main thing that I've taken up from this is there is such huge variety and variability, and it's be curious and get that information from a case-by-case basis on who you're talking to. Because I remember even when I emailed Denver, you're like, well, I can only talk about this, I can't talk about these other aspects. And I was like, whoa, yeah, they're so right that is obviously like their expert. So thank you for highlighting that to us. Sorry, Jason, I think you wanted to say something. Yeah.
I'm sorry, there's the last minute PS sort of thought. If anyone's looking to do research in the future and are wondering about like opportunities for this sort of in-depth stuff, I think there's some fantastic opportunities to look at, again, like the co-occurrences of sex workers and neurodivergency and disability, but also things like, I found it incredibly hard to study how much the impact of like toxic masculinity culture impacts how much data we even know about like male sex workers. Like that thing of like, would they turn up on research, would they not? Like that's another big sort of space. There's many others which we could always go into, and I'm sure you could email us and we would provide many other ones to people, but they were just some thoughts I wanted to leave people with.
I love that. Future, everyone go off and go do your research is what we're ending it on. But yes, just big thank you to everybody, and hope everyone enjoys the Northern Lights, as Lucy said before. Apparently we're seeing the Northern Lights tonight, so yeah.
So exciting, definitely.
So good luck on finding them. But thank you so much, everyone, and hopefully see you this is our final talk for this year, but hopefully see you all next year for our other talks that will be there in the future, and please stay in touch as well. Thank you.
Thank you.
Bye.
Bye.
Thank you. Bye.